Well, welcome everybody to Optometric Education Consultants National Webinar Series, Sunday night edition, Oscar night edition. And our topic tonight will be OCT and OCT angiography, real world case studies for enhanced interpretation, asynchronous virtual course. Our speaker will be my partner and friend, Dr. Greg Caldwell. He is a PCO grad. He had done his residency at PCO. He's been involved in numerous clinical trials through the FDA, the NIH. He has been lecturing extensively throughout the country, our country, and other countries internationally. He also served as the president of the Pennsylvania Optometric Association and served on the AOA Board of Trustees as well. And in 2023, he was named one of the top eye doctors by Newsweek magazine. So with that, please, a nice warm OEC welcome to Greg. Greg, take it away.
All right. Well, Joe, thanks. And thanks everyone for being here tonight. It's been a few weeks since I've been, I guess, given the captain's seat here, and it's always a pleasure to do it. And we're going to do some OCT angiography, kind of folding in a bunch of weaving in, some pathology, histology, trying just to really interpret this and make, interpreting OCT and OCT angiography. Regarding disclosures, I don't really lecture for any OCT companies, but you can see there Alcon de Dompe for lectures, advisory boards. You can see healthcare registries. Most important, this was prepared by myself. If I mention a company or Joe mentions a company, we're not claiming any bias, commercial bias, or superiority. You think you figured it out, or half owners of Optometric Education Consultant, but everything has been turned into the regulatory bodies and everything has been mitigated regarding that. Here's my practice. Here's my building in Duncansville, Pennsylvania. I'm a third owner in that. Basically electronic health records, seeing patients, optical, kind of full scope. We have IPLs and contacts and all kinds of fun equipment, and one being OCT and OCT angiography. What I try to do is take the science, try to translate it, interpret it to just kind of help make patient care easier for myself and for those who come and listen to the presentations. Now I'm going to take a little bit of a different course design tonight. I think we really should understand the OCT really in depth. I mean, with this axial Z scanning and this reference mirror, taking this I'm just kidding everyone. I thought this cartoon right here was the best about how this OCT, this is a picture of an OCT, beam splitters, but a miracle occurs somewhere in here, and it says here, I think you need to be a little bit more explicit here in step 2. I'm really not sure how this thing works, but man, it gets some really cool images, and we can have some fun with that. So with that said, I'm just kind of curious. I'm going to open this question up here, and my office has OCT angiography, or you do not currently have an OCT. And I'm going to open up this question here, true or false? In its early stages, diabetes primarily affects capillaries in the eyes and throughout the body. True or false? So what do you have? And diabetes, does it primarily affect the capillaries in the eyes and throughout the body early on? True or false?
Now, Greg, if you wanted to fill in that part where a miracle happens, I can explain it.
Sure, please.
Yeah, essentially, it's off the idea of interferometry, and light will be sent to the eye and compared to what it comes off that reference mirror, and there's going to be a delay, and based upon that delay or interference or interferometry, interference from the tissue, the machine will create piece by piece and put together a living histological section of that retina. So that reference mirror is important. The light goes up and back and compare it against to what is absorbed by the tissue, and different tissues will absorb in different ways. and or to different degrees, and that delay or interference from the tissue is how it puts together the living picture. So that's the
Very
miracle that happens in step 2.
So that was step 2, being a little bit more explicit. All right, appreciate it. So here we go. I'm displaying the answers for at least number 1. 60 or so let's say 85% have a form of an OCT, with 25% having OCT angiography and an OCT. It's kind of neat to watch that number. I think that might grow now that OCT angiography now has a CPT and we can get paid for it. And especially with, I was again at Vision Expo East and SECO seeing some really cool images, what these things can do now. And we have a 15% no OCT, no biggie, that's out there. So, and then with regarding the true or false, we have 80% or 79% saying it's primarily affects capillaries in the eyes, and then we have 22%. So I'm just going to kind of hold off on that until we get to some more of the slides. So OCT and OCT angiography both are becoming equally important in diagnosis and management and treatment that's out there. We have some diseases like plaquenil retinopathy, plaquenil, toxicity. That is not really, great to be trying to diagnose with OCT angiography. When it comes to diabetes, that was the diabetes question, using what I'm going to call the OCT-B scan versus OCT angiography, you're going to pick up diabetes in the OCT angiography since it's a capillary disease. Remember, diabetes is a capillary disease. That's why fingers, toes, kidneys, and eyeballs can be affected, not the major blood vessels. So OCT angiography will outperform, in most cases, that B scan OCT. So that's why, depending on what condition you're looking at in the practice, they're both becoming equally important because of the way the pathology occurs. Now, I think it's kind of cool. Remember back in the days, or at least Joe and I will, whenever the Stratus came out, we were blown away by that. Neither one of us grew up in our first and second grade of optometry school with OCT. This all came out after Joe and I both graduated, and we were blown away just by that 15 to 16 microns worth of resolution. Now, with faster processors and faster scanning, the spectral domain getting 50 times and getting up to, say, 30 to, back in the time, about 15,000 scans per second was what your time domain was. Now we're getting up into 30 and 40, gets you about 5 to 6 microns worth of resolution. And then to get in the angiography, when you start getting up to that 70, 80,000 scans per second, you're able to see what's moving and not moving. And the blood is what's moving. It's able to pick up on that blood, and that's how you get the angiography. So it's basically how many scans per second. You start getting up into these swept source images, they're doing like 120 to 150 scans per second. And with that, you get some really good resolution. And that's just kind of what I'm showing here. Here's your time domain. This again was, say that 10 to 12,000 scans per second. That was back in 2002. You increase those scans per second, say up to, say, 35 to 40,000 in the spectral domain. Then in 2014, when you start hitting that 70, 80,000. That's why some of the instruments, some people will say, can't you just turn on my module? Well, if you have a spectral domain that's only running at 40,000 scans per second, it just doesn't have the capability of producing that image. And that's why OCT has to get up to about that 70, 80,000 scans per second. And you can see with that, you get just different resolutions and different pictures that are out there. So inner retina versus outer retina, I wanted to kind of, instead of just kind of running through, everyone pointing out this is the RPE and this is the ellipsoid zone and blah, blah, blah. I just kind of wanted to point out some concepts tonight with regarding the retina and reminding, and just kind of pointing out, okay, down here's the choroid and sclera, here's the RPE, but the neurosensory retina, I just kind of like dividing it into the outer and inner retina. The outer retina is avascular. The outer retina is basically the photoreceptor. And I'm going to point out a little bit later the ellipsoid zone here. Right above it is the myoid zone. But this whole area is basically your rod and cones within the retina. And it's avascular. That's why you have the choriocapillaris down here to give blood. And then the inner retina is, so those photoreceptors are sandwiched with vasculature within the retina and then in the choriocapillaris. And that's what I have this kind of picture over here for, kind of just showing you the photoreceptors and those bipolar cells, and then the inner retina becomes all the kind of cross linking and cross weaving of all the different neurons to then make the ganglion cell to then axon to go make up the optic nerve. And then that's where some of the ERG starts to separate, right? When you start hearing about the ERG testing, the Redival piece of equipment. I don't have it in my office, but there's like an A scan, it tests the photoreceptors, and then you got the axon being tested. And it gets early detection, but you're just kind of testing different layers, whether it's the inner retina or the outer retina, and the way it's the responses are occurring. But I want to point out, though, between the inner and outer retina, there's a loose space. So the photoreceptors are tightly packed. The inner retina is tightly packed, and there's like a space. So I always kind of think of it as, if you put carpeting down in your basement floor, and then you just put some carpeting down, but if you had a leak and the carpeting was floating because the water couldn't get through the cement, but it was below the carpeting, you'd have kind of that space in there. So kind of think of there's a space in here between that inner and outer retina. That's important because when diabetes, those capillaries leak, it usually pulls to that space right in here. And it's also a nice little space when you start getting epiretinal membranes or vitreomacular traction for that lamellar separation to occur. So remember, tightly packed inner retina, tightly packed outer retina, but there's a loose adhesion in there that can separate out. And here's my question back in diabetes, is that it's a capillary disease. When you come down here and look what I'm going to reference today, we're going to call these the B scans when we talk about the traditional OCT. And then we look at the angiography. Obviously we're going to call that angiography. These are the B scans. That's the angiography. Typically, when you look for diabetes, it's in here. And when you look, you could see that on this kind of enfase, you could see that there's either exudates or hemorrhage. You could see a kind of a fluid space right here. You could see the retinopathy here, but you could see the capillary dropout. So I want us to think that, OCT angiography, really beneficial in diabetes. It's kind of helpful in macular degeneration. It's kind of for glaucoma. It's another data point for progression and analysis. But where I find is angiography is helpful in the diabetic patient. You can see here, I put this one on here. You can see that loose space where that likes to accumulate. Hyperfluorescence could be exudate or blood. You have to look. Spaces like this would maybe be fluid that's in there. So you can see what's happening right here with the capillaries creating this B scan that's down here. So just remember capillary diabetes capillaries.
Actually,
so
Greg,
with regard, go ahead,
if you
Joe.
want to start that one, if you want to start that poll, I'm gonna go back 2 slides once you start the poll.
Yeah, let me start that. I'll open the question up. Let me just do this real quick. Let me show the polling question because it's kind of animated. Orange, is this the macula? Or is this the macula? Blue macula, orange macula, blue macula, or orange? Is it orange or blue? Where's the macula? And Joe, tell me when to stop. Is it this
Right
one?
there. No, show them again with your pointer where the that loose adhesion is. Okay, perfect. Now point out, please, the RPE. Right. Now, here's what's important for people to remember. There is a loose adhesion between the sensory retina and the RPE. That's when blood gets in there, it spreads out. When fluid gets in there, central serous, it spreads out. But beneath the RPE is Brooks membrane, and there's a very tight adhesion between Brooks membrane and the RPE. So detaching the RPE from Brooks membrane is actually fairly hard to do. So that's why the RPE detachments are smaller than these sensory retinal detachments. The RPE is loosely adherent to the sensory retina. The Brooks membrane is tightly adherent to RPE. Thus, fluid will not spread out very well. Thanks, Greg.
What I'm going to do is I'm going to make a note here because there's so much that we could talk about, PEDs and central serous. And I'm going to write that down because maybe the next OCT, I'll put some bunch of images on it and you can bring that pearl up. It's a great clinical pearl. So which is it, orange or blue? And we have displaying here 80% saying blue and 20% saying orange. So the answer is, I'm going to close the question, blue is the macula. Remember, it's about 2.5 or 2 disc diameters from the fovea is where the macula is. So 1, 2, 1, 2, and going up. So remember, that's the macula. So when we look at those 6x6 scans, you're literally looking at the macula. So just a real quick, I took an Optos image here and just drew 5.5 millimeters. And so this is the macula area. I think sometimes we get lulled in that this is the macula where the fovea is. And just remember, there's the macula, the parafovea, perifovea as we go out. So fovea, para is a smaller space, and the perifovea is a little bit bigger. But again, when you're looking at OCT scan, usually the 6x6 millimeters, since the macula is considered, say, 5.5 millimeters down here, as it says, 5.5. You could see that when you're looking by a 6x6, just a few millimeter, half a millimeter off is pretty much the whole macula. So this right here is the whole macula that we're looking at. Again, this is just in here for completeness. In this course, I'm not going to go through all the different layers. I will highlight the ellipsoid zone in a second here in the presentation. Uh-oh. Are we not moving forward? There we go. So with that being said, let's kind of throw some clinical pearls into here. Let's talk about some OC predictors of progression. And this is going to kind of focus mainly in maybe macular degeneration, but this isn't just for macular degeneration. If you have other retinal diseases and you see like hyperreflective foci happening, or the hyperreflective columns, which is number 4 here, that's showing you that there's dropout in the RPE. And then you're getting the beams of light. That's just showing you, what's happening with the RPE. It's a sicker RPE. There's, reticular pseudodrusen. We have geographic atrophy. We got substructures and drusen regression. So what I want to point out is maybe in this one here, when people ask me to look at macular degeneration, I like looking at the choroid first, because as you can see here, the RPE really absorbs that light that's being sent in, the energy from the instrument. Remember, the RPE is black, and it can really absorb that energy, and then it hypertrophies here. Or hyperfluorescence, or that's not hypertrophy, but hyperfluorescence is what we're looking for. So it blocks the light down here, and that's what I want to point out when we come to these predictors of progression, is these hyperreflective columns. And the one I want to point out that I see a lot of the hyperreflective foci, but we'll point these out as we go through here. So hyper versus hypofluorescence is, again, if you look at the RPE, look how it kind of absorbs and creates that shadow down. This is a blood vessel right here. This is a blood vessel right here. And since there's blood in it, you get these columns. So you get that on those vertical cuts. That's what this is, the horizontal cut. The horizontal doesn't catch a lot of the blood vessels, but when you go vertical from superior to inferior, you'll catch those blood vessels and you get these columns. So some people will think that's exudate, but that's really just a major blood vessel, one of the retinal arteries or veins that's being caught and creating that shadow. So what can I learn from this picture? This is a drive home. Usually, fall or spring, not a lot of sunny days. We're kind of transitioning. We get these cloudy days. But what I'm pointing out is, this little beam of light, is poking down through the clouds. And here's another beam of light. I think we've all seen, beautiful pictures of this, here's this cloud coverage, but there's a hole and you see these beautiful beams of sunlight coming down through. That's the RPE. And if you ever take a fly all the time, you take off and it's cloudy or it's raining, you take off and then you finally get to whatever, 5,000, 6,000 feet, you bust through the clouds and boom, it's sunny. Well, yeah, the sun's up there. The cloud, get above the clouds, it's sunny up there. So we know it's sunny up there. That would be kind of in the inside of the eye. The RPE, and you get these little beams of light coming down. And that's what I'm going to kind of show with this picture here. So when I look at, someone with macular degeneration, I like looking at the RPE and or looking at the choroid. And the RPE right here, as you can see, is absorbing that light pretty well. But I'm going to take a part of the picture away. And if I take a part of the picture away, you can look here, you get these little hyperfluorescent columns. This RPE here is healthier than this RPE here. That's how you can use these clues to see what's going on with that RPE. This RPE, you can't like zoom in and see it. Maybe not yet, you can't. Maybe later in the future you will be able to, but this is pretty sick right here. I'll take the rest of the picture away. If you follow these outer layers, how they've atrophied, and the inner layers of the retina, how they just keep come crashing down, you can see this RPE in the outer retina is missing. You can just see right here how this just drops and drops. Just a terrible form of geographic atrophy that is here. You can see the choroid, the absence of the RPE, the absence of the outer retina. But look at how this all hyperfluoresces here. So I'll go backwards. You can see that this is the way it should look. You can see that this is slightly sick here, but then when you get to here, how much light and all this atrophy that has occurred. So what I like to look for is look at the choroid when assessing a macular degeneration patient. Kind of like right here, the patient with drusen. And whenever we're looking at this patient, I'm seeing this RPE. This is one of those hyper reflectant foci, right? What would this look like in the retina? This would be your RPE scar. So this is how sick and oxidatively stressed and everything is going on. Look how forming this scar, this RPE is dying right here. That's a reflectant foci. If that wasn't there before, that's showing that this macular degeneration is advancing in this case. Now, this is just with the angiography, so I'll go back. This is with the angiography off. All I do is I click on one of these buttons and it turns it on. You can see that there's blood flow through the retina. There's blood flow down here in the choriocapillaris. There's no blood flow in here. If these drusens start, like in this case here, that's starting to become a little bit more vascularized than maybe we want. We maybe want to keep an eye on that drusen. But right now we want to focus on what we were talking about with these hyperreflective columns and these foci. Here's another one right here. This is what in the retina, if you were looking at a picture, if you were looking with your 78 or 90, this would be your RPE modeling that you see. That's not a good sign. That's a pretty sick, advanced, oxidatively stressed macular degeneration. This is just another patient here. You can see that the columns are starting to form. Once you get columns forming, we know that how sick the RPE is. You can see what these drusen are doing and what's happening out here in this person's retina. This is just another patient, just kind of going through how I like to start looking at macular degeneration in a wide angle here, just seeing these beams of light. These beams of light are just showing you how broad and how sick this retina is getting, and allowing this light to shine through because that RPE is being damaged. Not too many RPE foci here, but I do want to point out, maybe I'll come back to this slide. Notice how when you come across this ellipsoid zone right here, the dropout, dropout, dropout. That's not good. We're going to talk about mitochondria here. Look at this down here, this here and right here. See how this is black? Good. There's a blood vessel here blocking that. Not good, not good, fading. This one is a good picture. I'm going to remember this one for teaching what concept that I'm going to be talking about here shortly. Now
Actually,
these
Greg,
are,
Greg,
go
you
ahead,
go back
Joe.
a few to that hyperreflectile spot. Keep going back. One or two more. Yeah, that's a good one. That you point out that hyperreflectile spot there. Yeah, that's what you're going to see as, in your drop down list, pigment clumping, or you're going to write down pigment clumping. And what that is, you've got really kind of a break and migration and hyperplasia of the RPE. And everything that Greg is talking about in terms of AMD comes down to this widespread sickness of the RPE. And that's really, I think, the genesis of what happens with AMD. And that's why it is so really relatively unamenable to the anti-VEGFs. Whereas if you had choroidal neovascularization from degenerative myopia, ocular histoplasmosis syndrome, idiopathic, you may find that one or two anti-VEGF injections solves everything. But that doesn't happen with AMD because there's so much widespread sickness. Those other conditions are more focal sickness of the RPE, and they're much more amenable to anti-VEGF treatment. That's all.
Yeah, so I think that's a good one here to kind of feed off of what you just said, Joe, is that think of the anti-VEGFs as Roundup. You have cracks in the sidewalk. Man, that looks ugly. I gotta spray it with Roundup. Psh, psh, psh. You go and spray it. Okay, you come back, the weeds are dead, but then you come back 8 weeks later, you come back 12 weeks later, and the weeds have grown back because there's cracks in the sidewalks, new seeds fall in, rain washes the Roundup away, and you spray the weed killer. And again, it's this repetitive process, just as Joe highlighted here. All these cracks in this patient's sidewalk, you're using the VEGF that's out there, and that's why you have to give those repeated treatments. And you don't have to do it as much as those other conditions that Joe mentioned. This is nothing more than geographic atrophy. I just kind of wanted to show you how in these OCT angiography, you could see the vascularization of the choroid and the choriocapillaris here with that, nasty condition called geographic atrophy. And luckily now we have there's C3 and C5 inhibitors that are out there. One by Apellis, one by Astellas, one called Syfovre, the other one called Izervay, in respective oils, C3, C5 inhibitors that were trying to stop this atrophy from occurring. But I thought it was kind of cool that we could see how much those columns are from this atrophy. Now we're not going to use the chat box here because I've kind of let the cat out of the bag a couple of times, but this is called the ellipsoid zone. We call it the inner and outer segments of the photoreceptors. What I'm pointing out here is this hyper-reflectant of this outer retina. And when I was building, 30, 60 hours of OCT interpretation, the ellipsoid zone, I was trying to figure out why certain structures, why they hypo and hyperfluoresced. And whenever I was reading like a histopathology paper of this, it said that the ellipsoid zone is formed mainly by the mitochondria is the ellipsoid zone, and it's of the photoreceptors. Now, right above this ellipsoid zone is the myoid zone, and it was in that same paper. So there's the ellipsoid zone, the myoid zone, and I remember from reading that paper, that's where the Golgi apparatus is. That's where What else? The endoplasmic reticulum was found in this spot. So it just kind of reminded me, that photoreceptor is a cell, and it's, and it does a very highly metabolic, and then it kind of gets wired up through here. So the mitochondria, and I'm not going to turn this into nutrition and into a long drawn out supplement or whatever type of talk. But remember, the mitochondria are highly involved with keeping the energy of that photoreceptor working. And if that's becoming diseased, then then things are going to die because there's no energy. Then I was flipping through OCT Connect, and I was always blown away by this being the mitochondria. And then this person put up this interpretation of OCT, OCT-A images. It's all referenced right here. And this is a picture from it. And I was looking through and I'm like, what? Mitochondria of the RPE. And it makes sense. The mitochondria of the RPE are down here. You cannot see this with an OCT. It's not that specific. But look where the RPE are or look where the mitochondria are of the RPE. And that's super, super important, as Joe was talking about with macular degeneration. Start wrapping your mind about macular degeneration and RPE and oxidative stress that's out there. So this is my only slide I'm going to talk about real quick, is that mitochondria produce the energy from organic matter. They live about 100 days. That's why if you do exercise, you can start flipping them from sugar and fat burning and so on and so forth. They produce 90% of the energy, but also it's not a clean system. Produces 90% of the free radicals. Now, with that being said, your brain has 1.2 million per single neuron. A heart has 5,000. A liver cell has about 1,000 to 2,000. But check this out. Photoreceptors, about 500, let's say, and RPE 700. So when you look at when you're looking at this line right here, this ellipsoid zone, it's the photoreceptor, it's the mitochondria. There's about 500 per photoreceptor, but more importantly, there's about 700 down here in the RPE that's there. And that's why, in genetic testing, and they start talking about complement factor H, and they're talking about ARMS. And here, look, C3. I'm just going to tie everything together. This ARMS right here, that is a combustion issue. They're having problems metabolizing. C3H, that's your braking system of the immune system. And if it's already broken because it has a C3, it has a CFH, sorry, CFH, that's the braking system. It's already broken. Remember, macular degeneration is kind of an autoimmune disease, or it is an autoimmune disease. And that's why high dose zinc you don't want to give, because zinc does slow down the braking system. So you already have broken brakes. You don't want to have them broken even more. And then C3 here, I thought was kind of neat because Syfovre, right, goes after that C3 in macular degeneration. So again, right here, it's the lectin system. Remember, this is the innate, this is the adaptive, this is the complement system. There's an 8-part series here on Ninja Nerd. And again, it's just trying to tie what you're seeing with an OCT out there, looking at the RPE. Joe pointed out that the RPE and Brooks membrane, they're tightly attached. But up here, there's a larger, easier to create that space. So that's why you'll see that small RPE detachment versus that central serous, as he beautifully pointed out. But you can see why these new medications are going after C3 and C5, because those are the broken SNPs. So I thought this was kind of neat, and feed off of what Joe was saying, is this is the way it should look. When you have the oxidative stress, the cross-linking occurs in the collagen bands. And this is what happens in macular degeneration, and you get this basal lamina drusen kind of building up here. So when you come to an OCT and you're starting to see a small drusen, I like to consider this as being pretty advanced macular degeneration, even though maybe the Beckman classification will call this no macular degeneration. Check this out right here. And look right here. And here. And here. And here. This is a little bit sicker than we think. These are your hyper-reflective columns. We have an autoimmune condition going on here. We might want to try to intervene as much as we can for this patient in that anti-inflammatory type of lifestyle. Because if we don't, or if they are just have really bad genetics and they have a poor diet and they don't want to exercise and try and help themselves out as much as they can, now you can see right here, there's that hyperreflective foci. You could see the hyperreflective columns. You could see how the RPE is breaking down. We could see the oxidative stress, the overactive immune system. We have the C3, the C5s. We just have everything. We have mitochondria death, RPE, basement membrane, and photoreceptor death all occurring. This is a very, very sick type of retina that we can see on the OCT here. Now, when we look at OCT angiography, we could see that in the inner retina, you could see the superficial and deep. Remember, it should be black down here where the photoreceptors are, and then it's bloodbath down here at the choriocapillaris. So it usually just looks like a bunch of white. So you can see the individual capillaries, superficial, deep, should be dark, and then it turns white on a lot of the images. And all these concepts that I'm teaching, they're not specific to OptiView or Cirrus. All these concepts could be used. So here's just an OCT angiography around the optic nerve. These are the radial peripapillary capillaries. Somewhat useful in glaucoma disease. Again, it's another biomarker that's out there. You can see the different images, they've got different depths. Where I use this one a lot over here on this right side would be for macular degeneration down here on these bottom two, or these right two, where it's dark and you can see the healthy choriocapillaris. In diabetes, I would be using these two. So a patient has diabetes and macular degeneration, this becomes useful. You can see in a nice 25-year-old, you can see how much blood is flowing through the choriocapillaris. We can see the blood in the inner retina. We can see nice capillary densities that are occurring. Now, what I wanted to point out, this was a very healthy 60-year-old man, so age really doesn't affect. So you can see the radial peripapillary capillaries. We have nice superficial and deep plexus, nice dark photoreceptor, and again, a nice little bloodbath of the choriocapillaris. And this is just fun to do. We were able to stitch these two together, and you can just kind of see what happens with when you montage these together. This is more or less just showing off the instrument because there's really no disease here process to kind of show you. All right, Joe, any questions or any comments before those are some concepts that I wanted to point out. Now we're going to kind of get into some of the what I think is the most common findings on OCT are the vitreoretinal interface disorders.
Somebody wanted to clarify, they heard right that you feel macular degeneration is an autoimmune disease.
Yeah, definitely is an autoimmune disease that's out there. The immune system is breaking down, and the immune system is attacking our outer retina for multiple reasons. And that's why, if you think about it, most of the treatments that we have that are allopathic, you're using anti-VEGF, monoclonal antibodies to slow and stop that immune system, and then Syfovre and Izervay, they're going after the complement factor system. So yeah, I consider macular degeneration an autoimmune disease that's out there.
Very good.
Anything else?
Nope.
Okay, perfecto. All right. So again, I figured I'd throw in what I pretty much see a ton of the time. It's these retinal interfaces. They get in the way when we're trying to manage glaucoma, and I'll try and point out a couple conditions there. They form epiretinal membranes. They cause one eye to be 20/20-ish, the other eye to be 20/20. So basically, I thought since I see these all day long, this is where I kind of focus a lot of the presentation after getting back the concepts. Now,
Hey,
whenever I
Greg,
went, go
Greg,
ahead, Joe.
you're gonna be talking more about diabetes, correct?
I will get into diabetes at the end. Yes.
Okay, because a question that come up, do you recommend doing retinal OCT, or maybe we should say OCT-A as well, on all diabetic patients, even if you don't see diabetic retinopathy?
Yeah. So my answer to a short answer to that would be yes. The good news is in our practice, we have about an 80 to 70 to 80% capture rate on a wellness. So even when a patient comes in for diabetes, we will do and a lot of times they opt in for it and they pay for the wide field imaging OCT angiography. But with that being said, yes, I believe that at least OCTA, if you had to pick one, if you didn't see retinopathy on your exam or photo, OCTA, but OCT and OCTA are very, very helpful in picking up early diabetic retinopathy. Now, there's other testing out there too, right? The ERG testing, and there's Raven cone contrast testing that's out there. But most of us don't have the ability to buy all these different instruments. So if you have a visual field in OCT and OCTA, I would, probably take, and which I do, my diabetic patients. Good.
We're good.
All right. So when I went to school, we had these different names for macular holes and so on and so forth. Then I started getting letters back from my retinologist. They were talking about vitreomacular adhesions and tractions and focal and this and that. And I'm like, where did that all come from? And then it came from this paper here, where some of the retinologists, or now most of the retinologists, use this international vitreomacular traction study. If you just Google that, it's very easily downloaded. You don't have to really be a part of a system. If you can't find it, I can send it to you. It's a nice document, but I'm going to kind of go through and kind of highlight some of these different types of where I've kind of, as this here, snipped it and highlighted it. So where I have results, vitreomacular adhesion, that's where that came from, is defined as a perifoveal vitreal separation, but it doesn't change anything morphologically. Then your vitreomacular traction can start to create schisis and pseudocysts. So basically, if you don't have any changes morphologically to the retina, then we're going to call it vitreomacular adhesion. If you start getting the changes, that's the vitreomacular traction. And now we have what they just call full thickness macular holes. So when you read the paper, you can go through and read it. There's vitreomacular adhesion, vitreomacular traction. They start calling them focal and broad based upon how much area they attach. I don't know if I really clinically treat anything different. They'll say that focal adhesions versus broad adhesions, the focal can be a little bit more risky of tearing and doing different damages to the retina. I don't put much weight in trying to decide whether it's focal, whether it's broad. Maybe subconsciously I do. Maybe I would bring them back at 3 months versus 6 months if one was focal or broad. But vitreomacular adhesion is probably usually a yearly follow-up. Usually found on things when I'm doing like glaucoma follow-ups and so on and so forth. The vitreomacular tractions, I might follow those up a little bit closer. And if it was focal, maybe a little bit sooner, but not a lot of weight. Joe, do you put much weight into focal and broad when it comes to discussing like adhesions and tractions and so on and so forth?
Not in terms of discussing, but I am aware which ones may be a little bit riskier, and I might be a little bit more prone to referring those patients, depending what it looks like. I'm sure you'll have some great examples that we can discuss.
Yep, absolutely. So vitreomacular adhesion, I mean, if you just read the paper, it says vitreomacular adhesion is equivalent to a stage 1 PVD. Most eyes have complete vitreoretinal adhesions at birth. So that's what I'm pointing out here. Basically, this down here, the vitreous is lining that whole front surface of the retina. So when you image it, you don't see it. So that would be, 100% if you want to say of a vitreomacular adhesion. It's not until later in life, like this here. Remember, this is the fovea. About here is the parafoveal. This whole thing is the macula. This is a 6 millimeter scan here of the macula. So a little bit of it is not, a 0.5 millimeter of it is not. Obviously, there's some drusen down here. But I was evaluating this person probably for macular degeneration, and you could see this is the vitreomacular adhesion in that perifoveal range, as they were saying, in this definition up here. So what we're looking at is this is a vitreomacular adhesion. Here's a vitreomacular adhesion here. There's no distortion. That's why we can call it. There's no distortion to the retina. I mean, there's a vitreomacular adhesion right through here the whole way. Now this is starting to lift up. I don't see any traction. I don't see anything going on here. If it wasn't for these drusen, I mean, I'd be following this patient probably 6 to 9 months based upon their degeneration here. But based upon this, I would see them back in a year. Joe, minus the macular degeneration, does this cause you, because of how nice this is, does this cause you any heartburn with this vitreomacular adhesion?
No, none whatsoever.
So this is just a vitreomacular adhesion. If you see it in your OCT and you want to document it in your chart, you could call it a vitreomacular adhesion, maybe warn them of PVDs and call you. Again, look at right here. Look at this column. I don't like seeing that on this. Here's another vitreomacular adhesion right here. And this one here is what I want to point out is I'm following this person. This is that 60. Well, we saw this before. This was that 60-year-old man that I showed you. And I was just taking it to get a healthy OCT-A to show you that there's really no difference from 25-year-old to 60-year-old. But he did have a vitreomacular adhesion. I saw it back then, but I didn't want to point it out because I wanted to use it for this part right here. So vitreomacular adhesion is what you would call this. There's no distortion to the retina. If I would see this, I would just tell the patient, look, you have an impending PVD here. If you get any flashes or floaters, give me a call, and I will see you back in 1 year. Remember, this is that 25-year-old person that I showed you. That was it right here. And remember that whole, well, at least not down in the foveal pit, but remember that vitrea face is hitting up against that retina face. So this would be 100%. This one's just starting to lift off. And that's when we call it a vitreomacular adhesion. So obviously these are macular degeneration patients, and you can see that this retina, this adhesion has totally pulled away, and this one here is still attached right here. So you can still call this a vitreomacular adhesion. I don't really see any distortion to call it traction, but obviously the bigger issues here are the macular degeneration. So you see these adhesions and tractions typically as your following the patients. Now, this is a fun one. I always like to say the vitreous is alive, right? The vitreous, it's oxidizing, it's pulling away. And here's a patient that I'm following with glaucoma. But if you look here, you could see that there's an adhesion or maybe some traction going on. But then there was a big change in their GCC, and you could see it pulled away. I made it a little bit easier here to see. You could see that this here is attached. The other side is attached, but when they came back, this is now has changed. Now that have to be careful when we're following these patients. That was the patient's left eye. If there was a drop all of a sudden from here to here to here looks pretty good, but from here to here this released, could that cause that worsening, that drop right there? And I'm going to say yes. I have seen people that that didn't have glaucoma. We were following their GCCs are super elevated. Then that traction lets go, and that GCC goes back to normal. So in your glaucoma patients that are typically older, be careful of that vitreous. Make sure you're looking at your scans, your B scans. That's why they're there. One, to check, make sure that the technician has scanned the right area. We're doing GCC. You can see the foveal pitch. You can see the adhesions, the tractions, and then this one has released over here. Joe, any comments?
Yeah, I've got a few. In fact, that is incredibly important interpretation, which you just pointed out. And please, guys, in a situation like that, write that down in your record, in your specific interpretation. Put that in there. That not all change is progression. There's a change, but I don't think that I think that probably it was always looking like that toward, on the far right, but it was masked by some lifting up by the vitreous. Now there is a question, and I'm also going to share a story from last week. Question on these: watch versus refer, also based on patient's acute awareness or anything else? And I think we're going to get into this. So how do you tell the difference between VMT and an epiretinal membrane? I think we'll probably talk about that in just a little bit.
Yep,
But
the epiretinal membranes are coming up here. We're just kind of starting off with the adhesions. We'll go to tractions, and we'll go to epiretinal membranes.
Now, watch versus refer based upon the patient's awareness or anything else. What makes you watch and what makes you refer, Greg?
Yeah, a vitreomacular adhesion, I'm going to watch all day long. I'm going to. So my answer is that two things: always refer when you're uncomfortable. Two is I worked in a retina clinic for a few years, following retinal detachment surgeries, watching all the injections, so on and so forth. So I feel a little bit more comfortable maybe than the average person, and to get that maybe luxury of working in a retinal clinic. But I also filter back when I was working with the retinologist, if I would send it to them, what could they do? So that's probably my biggest barometer, is that I don't really say, well, I don't want to be the last person to, if they get a macular hole. If they have a vitreomacular adhesion, if I send it to the retinologist, they're not going to they can't do a VEGF injection. They can't do any treatment. They're not going to laser it. They're not going to do a vitrectomy. I always say I can follow them as well. But as soon as you start getting some of these more complicated, you might want to get an opinion for them to say, okay, nothing can be done. You can watch it and we'll see it when this happens. So I think as you start getting closer to the loss of vision type, that's when you can start referring. But Joe, if you want to add to that, you can certainly add to that.
No, I agree with you. The story I want to share, I think it was last week. Now a patient came in first time she came in for an emergency. She already had a macular hole in her right eye, surgically treated. Another state. So she knows about this. And she was describing things that she had seen on her OCT in the other office. And her complaint was like she had a line in her vision. Like there's a line in the vision. It happened suddenly, and she felt she was getting another macular hole. So line in vision, something discontinuous. You think, Watsky Allen, maybe there's a hole. She had a pristine OCT, perfect macular architecture. Now, there were some records from her out-of-state retinal specialist. There's no OCT in there, but they had a pretty good description of her OCT, and they were describing vitreomacular traction that they were watching in the fellow eye, the eye that did not have the macular hole. Now this was her left eye was her symptomatic eye. She was very, very anxious that she was developing it. And as I looked at it, I said, look here. I showed it to her. She had a certain sophistication in somewhat understanding what she was looking at, the OCT, and it was a pristine OCT. And I said, look, I don't have an OCT from your other practice, but I have a pretty good description, and what they were following is not there. So basically, I think her symptoms were her VMT released and she went back to a normal macular architecture. I mean, she saw it, she did understand the OCT, but I still think to this moment she thinks I'm FOS. That I'm just missing her macular hull. But no, it was a pristine, and apparently they had been following VMT elsewhere. I had a good description of it, and I was not seeing any of that in the OCT. I had a hard time convincing her she was actually okay.
Right. Yeah, well, those are tough sometimes, yeah.
You can't save them all.
So, focal or broad, it can happen in VMT or vitreomacular traction or VMAs, vitreomacular adhesions. It's that 1500 broad mark that's out there, that we need to talk about. So, learn how to predict acuities is what I have here. When you look at the outer retina and you're looking at the mitochondria, you're looking at this area. This is where the photoreceptors are. This little hump right here, I'll just ask yourself, is that normal or is that edema? We weren't really sure when we had the spatial domains, but when we finally got to the to the higher resolution spectral domain, we were able to see this, and this is where your cones are, right? Remember, the cones are kind of tall and thin, the rods are short and fat. So this is not macular edema here. This is just what the foveola, that little hump right there, is where the cones are. So when you predict acuity, I used to turn this into a polling question, which one has the better acuity? It's this one up here, because if you look at the RPE, you can see that the mitochondria line is still intact all the way across. That means the myoid zone, the photoreceptors, you have all this going on in your inner retina, and the wiring is all intact. There's that loose adhesion. This would be what they call a maculoschisis. This is not a lamellar hole because this is still connected here. So you have this big maculoschisis. You have a vitreomacular traction. This is a vitreomacular traction. This would maybe be a broad. I can measure it. But remember, the optic nerve is 1,500 microns. So, focal approaching broad. This is definitely focal. But look, your acuity is going to be a lot worse right here. Now, in referring, I would maybe sit on this one. I would watch it closely. I don't think the surgeon's going to do anything. There used to be Jetria. None of that stuff is used anymore. They're not going to do a vitrectomy on this. They're probably going to watch it, so I could watch it and send it over. It starts to progress. But this one here, I would be referring over. I don't like what's happening here to this outer retina. Again, another big maculoschisis, lamellar separation, traction, and now you're starting to get damage to that outer retina. So I would be, this acuity is going to be dropping. This one's going to, I would say, be 2025 right here. This one down here could be in the 2030 to 2060 range. I would be pushing that out. So learn how to predict acuities so that it all makes sense. Now, this is a focal vitreomacular traction. You can see here the vitreomacular adhesion. And the reason why I call it traction, because of this little morphology change right there, little traction. You got a little bit of a pulling up on your retina. So it takes it from being almost an adhesion until there's that little bit of a traction. Here, it's just a whole bunch of just labeled. Again, I like to just look out here just to see what's the acuity of this patient is going to be 2020, 2025-ish. Definitely if they cross one eye to the other, they're going to have a definite difference between the two eyes because the Snellen acuity isn't that, sensitive. But it may be a broad vitreomacular traction here, a focal one over here, and you can just see what's happening to the retina all across here. But I think if I would refer this to the retinologist, I don't think they would do anything with 2025 or 2030 vision for this patient. This would be just an observation and seeing them back 2, 3, 4 months, whatever you feel comfortable following after explaining it to the patient. Again, another vitreomacular traction here, all because of this adhesion and that little morphology change right there. Here's another vitreomacular traction. I'm starting to get a little bit of concern down here. Is this fading? Is it just poor signaling? And again, maybe a little bit closer follow up on this vitreomacular traction. And the key is sometimes the terminology can change as you scroll through. So all of this stuff is a lot of cube data, and your definition of what you're calling things could change as you scroll through. Nothing really changes here. Watching this mitochondria line, the ellipsoid zone, you can see this, it's still focal, traction, which is a little bit riskier than the broad ones. And you would maybe follow these people a little bit closer. You can just see kind of this double membrane type of finding. Here is just a really wide field. And this is an 8 mm by 12 mm, but just really cool that you can see what's happening to the vitreous. Remember that the vitreous is attached around the optic nerve, around that foveal, way out there at the vitreous base. This is just a really cool picture, again, of just a vitreomacular traction, just showing off some of what these instruments can do now with these high resolutions. Now, Joe, before I shift gears from adhesions to tractions, we are going to cover epiretinal membrane right now, but are there any questions there?
Kenneth asked a question we're going to get through, I think in a minute, difference between VMT and ERM. But one came with a significant macular traction, VMT. Do you advise the patient limit certain activities as you watch them more closely?
Probably off the top of my head would just be like, hey, don't take up boxing now. I'm not sure, reading, I would tell them just to read away, exercise, I don't know if any problems with lifting or, I certainly wouldn't tell them not to worry about flying in planes. Everything's pressurized. Just running through a bunch of things here, maybe watch traumas to the face and head, those types of sports or activities. Anything you could think of, Joe?
No, and I think we can make an argument that if something happens, you may actually cause it to release. So I would not speculatively tell a patient not to do certain things. I mean, obviously boxing, but there are things that I think we tend to worry too much about. Do we really tell people who men who have small optic nerves they shouldn't use Viagra for the risk of a non-arteritic anterior ischemic optic neuropathy, or a person who is diabetic or obese, you can't use Ozempic for the risk of a non-arteritic anterior ischemic optic neuropathy. We're making some pretty tough judgment calls there, which probably are not warranted.
Good examples there. Yeah, absolutely. Taking it from outside of the VMT to an optic neuropathy. Yep, absolutely.
Oh, another thing. I'm sorry. One more thing. I don't know if you had it, and I don't have a good image, or I don't think I remember the patient, but I've had patients referred to me for unilateral disc edema, and when you actually do the OCT, you find they have juxtapapillary traction, and the optic nerve is fine, but that vitreous is yanking up on it and makes it look like disc edema.
Yeah, that'd be a good one if you ever get one. Send it my way. We'll throw it in there and we both can talk about it. So, all right. So we're going to transition here from vitreomacular adhesions. I'm just kind of clicking here to remind us. These are the adhesions. These are the tractions. And now we're going to talk about epiretinal membrane. Now, what's the big difference is in order to get this epiretinal membrane, which has all these different names, right? Preretinal gliosis, premacular fibrosis, macular pucker, blah, 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 blah. In my mind, in order to get this band right here, you need a break in the internal limiting membrane, right? You need a crack. Where does that usually come from? That usually comes from a posterior vitreal detachment. So you need the crack. It could be from a laser, maybe it could be from a trauma, but you need a break in the internal limiting membrane. Now, remember, where does this membrane come from? These epiretinal membrane. The hypothesis is there are astrocytes in glial cells trapped in that inner retina, right? Remember all that wiring and cross wiring is? And when you get that PVD to break and crack the internal limiting membrane with that little micro crack, you're not going to find it on an OCT. It's way too small. Those cells, those retinal glia cells, astrocytes and glia cells, grow on the surface of that retina. And that's why when I worked at the retinologist practice, when they used to peel these epiretinal membranes, they wanted them to be mature because they were kind of like jello at first. Is that when if there was an epiretinal membrane there and it really wasn't creating traction and it was young, it was kind of like jello that was just put into the refrigerator for about maybe 20 minutes. You'd go in and try and grab it, but it was still liquidish. It was gelish and it was hard to grab, right? But if you let that jello sit overnight, you can cut it and take it out, take a square, and you can eat it. Epiretinal membranes, the point of that whole discussion is that they mature over time. And as they mature and they start get hard and crinkly, they can start to do different things to the retina. And then when that epiretinal membrane forms, because there's the crack, maybe the PVD was over here, but that membrane grows across, but now there's the posterior vitreous and then it sticks to the back surface of the vitreous. It's now grown onto the retina. Now that part of the vitreous starts to pull away. You start to see some really neat findings on the OCT from the epiretinal membrane. So the difference with a vitreomacular traction, vitreomacular adhesion, it's just as that is lifting away, how much, glue is there. In order to get an epiretinal membrane, you have to have a break in the internal limiting membrane to allow those cells to grow out and there to be a true type of fibrosis or scar tissue. So, with that being said, that's why you see all different types of findings with epiretinal membranes. Like this one has grown across the surface, and it's probably just kind of contracting. And what it has done, it has pulled out the foveal pit, and now you have these little pseudocysts. Nothing a retinologist is going to do with this. They're not going to go in and peel that. This patient's vision, this inner retina is intact. They might have 20/20 minus vision, 20/25, 20/20 on the Snellen chart. And when they cover one eye, hey, doc, it's not as clear as over here. Yeah, I can see why, because you have this epiretinal membrane. It's creating a little scattering of the light. But man, I don't know of any retinologist that's going to go in. There's no treatments for it. There's no way I can dissolve it. The VEGF treatments don't do that. We just have to watch this. And this is where the onphos comes into play. You could see here that the membrane is really contracting over here between the foveal pit and the optic nerve. And you could see what it has done. It has pulled and it has popped out that pit and created a little bit of a cyst, a pseudocyst if you want to call it, but it's a cyst that's full of fluid. It's most likely aqueous that's filling in there. I don't think capillaries are leaking. Remember, aqueous does drain through, a little bit drains through the back of the eye. There's some type of fluid in here, and you can see what's happening. This is called an onphos technique. Now, this is probably one that's really beautiful just to kind of show you what caused it. Here's the PVD, right? This PVD formed, maybe it pulled away from the optic nerve, pulled away, cracked the retina, and those cells that are trapped in this retina, those astrocytes, glia cells, those retinal tissue cells in that inner retina, not the photoreceptors, but the inner retina, have now leaked out and grown across the surface. That's when someone asks, what's the difference between VMAs, VMTs, vitreomacular adhesions, and tractions? It's really not an extra tissue. Epiretinal membranes are kind of additive in a sense. It's the cells that were trapped and confined all of their life in that inner retina. And now, because of some type of trauma, in this case, this PVD here most likely is the cause, and you're using this on-FOSS technique, and you can see how large this epiretinal membrane is. That's why I love this technique, because this really drives home to the patients. Whenever you see this, I switch over to on-FOSS. It's already in there. You just have to know where to click to find it. Hopefully it's in focus, and you can see the magnitude of these epiretinal membranes. And these epiretinal go ahead, Joe.
Yeah, I think one way to say what is the difference is one is physiology, one is pathology.
Yeah, that's a great way of putting it. And here is just, then they do different things. We've shown this pseudocyst right here. You could see right across, this is the internally limiting membrane is down here. This is going to fill up with fluid. It's most likely going to fill up with aqueous. Again, vitreous. When you do a vitrectomy on someone, you take the vitreous out and you put balanced salt solution into the eye, the BSS eventually rinses away, and then the eye is just filled with aqueous. So when you see these little spaces here, it's not air. It's not really leaking out fluid. It's just filling in with most likely aqueous or just fluids of the eye, but not things that are leaking. So these really aren't cysts. This is just the membrane being grown across this. How did you put it, Joe? This histology versus what? What was it?
Physiology versus pathology.
So pathology here is the epiretinal membrane, and this is all normal anatomy just being tugged upon, creating these little cystic areas. But this is the internally limiting membrane. That's the epiretinal membrane. Again, the same thing right here. There's the epiretinal membrane. Right there is the culprit. PVD, most likely the culprit. That's probably the one. Crack the retina somewhere. Allowed those glial cells and astrocytes to grow across. Now, imagine if that vitreous was still attached while this was happening, and then the vitreous starts to pull away. Now you start getting some really cool findings that can occur. And you could get some PVDs and epiretinal membranes and vitreotractions, and then you can end up with things like full thickness macular holes. Joe, great insights. Do you have any comments?
A couple questions came in. What's the criteria for an ERM peel? Acuity, patient demand, surgeon's opinion?
Mine is going to be about 20/60 or worse of an acuity that's out there. You start getting to 20/40, 20/60, symptomatic patient, you're going to send them for a peel. But here's the kicker. I tell the patient, I'm going to send you for a peel, but they're going to take out your vitreous. And I just had this breakthrough moment about 4 months ago. I want to talk about this point here in a second. You're going to then, after the vitrectomy, 6 to 12 months later, form a cataract and have to go through cataract surgery. So the process of sending you is great, but I want you to let you know that it's just not as simple as peeling that membrane. This is an 18-month, we're going to be friends, retinologist, cataract surgeon, happy to send you. Because I don't want them to be mad at me for not giving them the full story. But it would be what does the outer retina look like? What's the acuity and symptoms?
And
Anything you would add to that?
yeah, and make sure you understand what the surgeon likes to do. Not everybody likes to do a membrane peel. Not all retinal specialists feel comfortable with it. Other retinal specialists consider it their specialty. So they don't all, if you send it to a person who is a reluctant peeler, that person probably will tell you, let's just observe. And you may have somebody who has a good skill level with this condition, and they may go a little bit earlier. But visual acuity 20/60, I would certainly bring it up. They've not brought it up to me. Maybe even 20/40. What is their symptom? Usually it's not just the acuity, it's their symptomatology. It's like distorted for them. And here's another one. ERM is always post VMT and PVD. What do you think?
Yeah, we could probably say that. Because you have to have, well, I guess in the case of if they did had laser work done, they had like uh, a horseshoe tear.
Mhm.
Well, that would be a PVD. If they had some diabetic retinopathy treated
Mhm.
and they were going in and cauterizing and they broke the internal limiting membrane, that could be a case where I would not say always. In these,
But I would say often.
often, yeah,
And,
majority,
and
yeah,
what I remember a term where these were called idiopathic ERMs, and it's not really idiopathic when more likely than not it was a violent PVD. Laser, as you
right,
said, maybe a stray laser, somebody gets a laser beam,
right,
or I'll give even just cataract surgery, maybe disturbing the vitreous or the light from the operating microscope. I can tell you that I developed an ERM after cataract surgery that I know was not there because I had pre-cataract surgery OCT. I mean, it doesn't affect me at all. It is not over my macula, but I did develop one after cataract surgery.
yeah,
So it makes a
yeah.
comment. One of
I
our
would say
retinal
often.
groups,
That's
yeah,
a good one. Yep.
one of our retinal groups in Omaha is not taking detachments, just doing injections. Okay. Many patients complain about distortions after peels. Thoughts there?
Oh yeah. It's already distorted. There's no guarantee it's going to go back. The
Mhm.
brain is already kind of adapted. Anytime a peeling is done, again, the cataract forms. I tell the patient, say, look, this isn't going to 100% resolve. The corn rows have been pushed around. You're kind of neurologically adapted. Um, yeah, I mean, they don't always go back to being normal.
Yeah, it's hopefully just less distorted.
Yeah. So I had this breakthrough. What I wanted the other day was about 4 to 6 months. And again, I'm not going to get into all this kind of nutrition stuff, but someone was talking about vitreous and they were talking about, there's some formulas out there that maybe can help prevent it. And I was thinking and digging around it and I found this slide where this guy put all this antioxidants, all the different antioxidants that are found in the vitreous. And that's why it clicked on me that this metabolically, I used to say the vitreous was worthless. It was a pain in the butt. It came through the birth canal. And after that, all it did was screw up all my testing for glaucoma, all this vitreotraction, vitreomacular, but it has a huge advantage in that it's full of antioxidants, and that's the connection. The retina is this metabolically active species spilling off all this, say, free radicals. And when you take the vitreous out, it's not the trauma. When you take the vitreous out, and there's just aqueous in there, all those free radicals bathe that cataract. And that's now, in my mind, why a cataract will form in 6 to 12 months. Really, it's not the trauma from the vitrectomy that does it. It's just that vitreous it's a antioxidant bomb, and we don't realize how much it protects the front of the eye. So that's my little fun pearl of antioxidants in the vitreous. All right, full thickness macular hole. All right. Basically, when it's full thickness, you just send everything out. They used to be stage 1, stage 2, stage 3, stage 4. That's what Joe and I grew up on. We used to grow up on 1, 2, 3, and 4. And if it was small, large, blah, blah, blah. If there was traction, if it would totally release the PVD, it was a 4. If it was a large hole, measuring the size of it, like we were 1, 2, 3, 4. Then all of a sudden it was small or medium, full thickness with VMT, with VMT, without VMT. So that's is where some of that terminology came from. And it's kind of funny in my area where I send to the retina folks, There's some older founders of the retina, and there's some newer people. When I send them over, it comes back, yeah, that's a stage 3 macular hole, or it's a medium or large full thickness with VMT. So it's kind of neat. A couple of them still use the old terminology, and some use the new terminology, and that was back in 2013 when this came out. So, I mean, it's going by the aperture of it. But to me, once they have whether it's a 250 micron, 400 micron, it's a referral for the patient to decide whether or not they want to get it fixed. So I like seeing this whenever this happens. Remember, we were looking at the RPE. See how this is hyperfluorescing? I like that. Right? It's going to hyperfluoresce because there's no tissues here to grab it. I don't like it to be missing. So if this is missing, so in other words, if this came in and the patient's like, yeah, I don't know how long it's been there, and I showed you that geographic atrophy and this was all lighting up down here and there was no RPE, you could close that macular hole and I would bet you they wouldn't get much vision back. And looking at this, I bet you they would get a pretty good amount of vision back based upon, the RPE being healthy, and if they can get those photoreceptors back in, and now they can with a lot of their instrumentation that's out there. Joe, any comments on that before I move on? I see you looking.
I was looking at a comment, not really a question. Somebody mentioning that a lot of retinologists and medical versus surgical. This is actually, you make a very good point here on that last one, is setting the proper expectations. Now you have loss of the RPE down there, and you may decide, well, I mean, we don't make the decision, but together with the retinal specialist may make the decision that it is not worth doing surgery for, because you're not going to get much back. But if you have something good down there, like you have, you may have an expectation they maybe get a 20/30 back.
So the key is it's when they have the full thickness macular holes, try to get them referred as quick. Sometimes the retinologists are busy, and maybe ask if they can get in a little sooner, because the more wear and tear to that RPE, the less likely chance, or the more likely chance of damage, less likely of getting some vision back. And this was just kind of showing, going by this is a large, because it goes by the horizontal measured linear with the across at its narrowest point. Well, this is, I don't need to pull out my measuring instrument. Yeah, that's 400 microns. This is less than 400 microns. There's your operculum. I mean, I just think this is what you can see with some of this technology out there. You can see sometimes I'll do black and white, and then I'll turn on kind of the color just to kind of maybe highlight to the patient what's going on. But you can see the full thickness macular hole. All right, polling question number 3 here is, you just saw patients with full thickness macular holes, and I'll go back to that and show you. But what are they going to say? So you're going to show these people right here, right? You got a full thickness macular hole. You got to go for a vitrectomy. You most likely have to go face down. That has changed, whether it's been 2 weeks or 3 days or whatever, what all happens with the patients, but it's not a fun surgery, right? So these full thickness, look how it goes. There's no inner retina. There's no outer retina. That's why it's full thickness macular hole. The VMT, this is without vitreomacular traction. This is without vitreomacular traction. Again, another full thickness. The RPE is intact. This one here is probably early, good chance of getting vision back. You're going to talk to them, and then what are they going to say? Doc, what's the chance of this happening to my other eye? Right? So what's going to be your answer? Yeah, it happened to your first eye, right? Is it's going to happen, to your other eye? Or do you consider yourself lucky or unlucky? Or just going to make up a percentage and say 0 to 6 or 54? Or is it dependent on what you see in the other eye? And let me throw the display up here, what's happening. And we have, a couple people saying, yeah, it happened to the first eye. Why couldn't it happen to the other? Get someone joking around, hopefully saying, do you consider yourself lucky or unlucky? 0 to 6%, 54%, or it depends on the OCT finding at 61%. And that's exactly what it is. You got to image the other eye. And really, the only test with all the testing that's out there is to use an OCT. Can't really do a visual field. I don't think ERG testing or Raven cone contrast testing, I don't think any of that is out there. You just have to look at the other eye. And there was these things at one point called stage 0 macular holes. And the point is, if there's no vitreomacular traction, it's basically 0 to 6%. But if they do have, and this is the paper right here that I'm referencing, and anytime you see Duker and Fujimoto, and I'm sure Schumann, but anytime I see Duker, these are the guys that invented the OCT, right? All that stuff that Joe was talking about at the beginning, and I was showing these are the people that invented this instrument. So when I see papers, I like to read them, and this is back in 2005. But basically, they're saying if you don't see any traction, and they go through and define everything here. But if you do see traction, the presence of a stage 0 macular hole in the fellow eye is a significant risk. And they pointed out right here 54%. So 54%. And they went through and they classified what they were seeing. But basically, it's vitreomacular traction is what you're looking for in the other eye. So impending macular holes, VMAs, vitreomacular tractions, if you see that, so the answer to it is, what are you going to say to the patient? You just went through, you told me you have a small, medium, full thickness, with or without vitreomacular traction. They have to see the retinologist. They're going to do some type of surgery. They might have to go face down, get bubbles, do all this stuff. Okay, doc, what's the chance of this happening to my other eye? Very low percent, 0 to 6%, based on what you read and what they have pointed out in that paper, if they don't have any traction, as high as 50-50 or 54% if they have traction. That's out there. Anything you'd like to add to that, Joe? As I'm
Well,
doing this polling question here, would you refer this macular hole?
yeah, I think that if you have in the fellow eye a complete PVD, and there's nothing that has happened, the likelihood that that eye now developing a macular hole is really pretty small.
Yeah, that would be like year 0, say maybe 6%, maybe if they form the PVD, they can form that epiretinal membrane, right? So I think that's the key here. But if they form the epiretinal membrane, it's just going to grow across the surface. It's probably not going to be any vitreous to tug on it. So if you have that complete PVD, it's at 0 to 6%. If they have traction, it's going to go up to 54%. Would you refer this macular hole? Any comments, Joe?
No, I'm gonna look at the chat, see if there's any questions. No, we're good. We're good on that.
All right. Let me just go through display here. And I got 66 saying yes and 34 saying no. And there's no right or wrong answer to this one. I would not refer this. I feel comfortable enough following this. If I look, this patient's vision is going to be, and it is a macular hole. It's just not a full thickness macular hole. This is what we call a lamellar hole, right? The lamellar hole, we have the RPE intact. You can see that the ellipsoid zone and the photoreceptors, there's that loose adhesion I was telling you back right earlier, and I pointed out a couple pearls, is that you have the inner retina separating from the outer retina. There's that loose adhesion. And because you can't really see that tissue there, you could call it a macula schisis, but you could also call it a lamellar separation or lamellar hole. And I would follow this, but not saying that the ones that want to refer away. But most likely, They're not going to do jet tria on this. I haven't heard seen a jet tria done for a decade now, but
Mhm.
they're not going to do a vitrectomy. They're going to observe it, and I can observe it well. But if you want to get an opinion on it, get an opinion. Joe, any comments?
No, I agree with you. The whole Jatria thing, I had not heard about that one for a while. And actually, when you had an example up earlier, very early, I would have said that might have been something they would have tried Jatria on. But they had a whole host of issues with that. There was only for very specific type of lesions, and they had some complications of vision loss from it, mostly because they weren't, I think, diluting it properly.
So these are just more lamellar holes here, just showing the separation. And again, it all depends on what cut you're looking at. If you look at this one here, this would be more of a macula schisis. This here, you can see the lamellar hole, the lamellar separation. But all these patients are going to have pretty good vision. This one here is an epiretinal membrane creating a lamellar hole, but the vision is still good. The outer retina, the photoreceptors, the cones, the rods, they're all intact. You can see right there is where the rods and cones are ending, and then your inner retina is separating kind of from this little kind of can opener type of traction, which is what I was trying. I took a picture and got my iPad out and the epiretinal membrane traction is this way. This is your inner retina. This is your outer retina. Patient had 20 to 20 visual acuity. The inner and outer retinal layers were separating here, and there's an epiretinal membrane. Then it comes down to a pseudo hole. And here's what I kind of think of a pseudo hole being. Remember, you have a foveal pit, it's like a bowl. And so when you get that break in that internal limiting membrane and those cells leak out, just think of those cells just kind of lining the inside of that bowl, and then they contract on themselves. They just kind of form in there, and it just distorts that foveal pit. And that's pretty much what I'm seeing when you read the definition. Invaginated or heaped foveal edges, a concomitant epiretinal membrane, steep contour, no loss of retinal tissue. And it's just kind of hard to get them, but here's an epiretinal membrane. You got a distortion, you got steepening, you probably have that epiretinal membrane down in there and it's contracting and kind of like a flower, and then it flower's kind of closing up on itself with that. So, pseudo holes, they used to do that because then when they would do this and you shine the light in there, you would just get this intense looking type, or if you take a picture of it with a camera, all that light comes out and it looks like a hole, but it's not a hole because they have 20/20 or 20/25 vision. All right, so let's see how we're doing here. So Greg and Joe discussion, comments in the chat box. So we don't have to do that. If you want to put a comment in the chat box, go right ahead. But what I want to point out here is we have a lamellar separation. We have a lamellar separation. A good point, good thing here. Joe pointed out earlier. He said if they have a PVD, there's a total PVD, at least in this area, a little operculum here, but the drawback is they have a full thickness macular hole. So this is going to be referred. You can see the light going down through here. That's not a bad sign. It's just there's no tissue there to absorb it. The RPE is intact. So Joe, there was really nothing. I just had you on here in case you just wanted to throw some expertise in there of anything that I didn't cover.
Well, no, I mean you see the operculum up there, and that's your retinal tissue, and that's not going to be getting put back. So bring it together. There may be some reduction in vision, but the fact the RPE is looking still pretty healthy and it's pretty small, we should probably have a pretty good outcome on this one.
And then diagnostic changes on the cut being studied. So this is all the same person. Look at all these different cuts. So here I would call it like a pseudo hole, a pseudomacular hole, because it's just distorted, maybe a little epiretinal membrane. Down here, maybe a lamellar hole, because right there it's starting to separate. So we got a lamellar hole here because of the layers, the inner and outer retinas are starting to separate. Definitely a lamellar hole here. Oh, clicked too fast. A lamellar hole here, and maybe a little macula schisis here. So as you can see here, as I go back, all I'm doing is just kind of clicking from looks like 11 and 12, 13 and 14. And by going from this there's a pseudo hole. This goes to a pseudo hole with an early lamellar hole. Here we still have a lamellar hole down to 13 and 14. We might call this a little maculus schisis down here.
Hey,
This
Greg,
one,
before you
go
go
ahead,
on,
Joe. Yep.
Rhonda is asking, how often do you see a patient with a partial thickness macular hole? And I think there's two ways to answer this. Like, how common are they? They're not that common, but I think she might be asking, how often would we bring them back? I think, Rhonda, if you want to clarify that, it's not like how frequent are they, it's like how often would we bring them back, I think is the question.
Yeah, I guess if we're asking like these lamellar holes here,
Mhm.
I would say that they're, when you start getting into epiretinal membranes and different types, depending if you look at all the cubes, if you go through and you scan, you could probably find lamellar if you're calling this a partial. You might find a little bit more frequently by imaging everyone and then looking at all of them, but I would still just follow them. And then, if it's the first time they've ever been told, I always shy on a short follow-up. Oh, I've never seen this. Okay, I'm going to see you back in 2 to 3 months. In 2 to 3 months, we're going to see if there's any change. If there's no change, then we're maybe double that and get you out to 4 to 6 months.
Mhm.
So the first time that I see things like this, and they're the first they're hearing it, shorter follow-up and imaging is certainly probably the pearl that I would give, rather than saying, we'll just see you back in 9 months. So the shorter follow-up would be the way to go.
Yeah, I would probably say every 6 months for 2 years, and if nothing changes, then it probably once a year with, with OCT.
So take a look at this one here. Go back here, see how we're doing. Did that answer the question, Joe? Did we answer that question? I don't want to be moving on without
I think we did.
Okay. So look at this vitreomacular adhesion. No, I'm looking here for morphology. I didn't like this. And I didn't like that it was affecting the outer retina. So, Joe, I just have this here. Does that look very benign or very like malignant or benign or concerning?
It's a little concerning.
Yeah, it's concerning, but it's not like scary. Like, wow, you have this almost ready to lift off. Man, just a good cough or a sneeze, this is gonna pop away. But I didn't like this. I didn't like that the photoreceptors. Remember that I'm okay when that inner retina is involved. I don't like when the outer retina is involved. So I said to the patient, I don't like that. Please come back sooner, which they did. 8 weeks later, and look what happened. They tore open. You
Mhm.
can see this is, I guess, if you want to use the terminology, this would be a small, full thickness with VMT because you can still see the traction is still right here. This one was able to be referred out. Still at this point, I bet you they were 2025, 2030. They had 2020 vision. We caught it so early. I called the retinologist up. I have his cell phone. I just sent pictures over. He got her in that day, and the hole was closed like within 5 days of seeing it, and had a really good outcome.
Now, Greg, go back to the previous one. I'm going to suggest to the audience, forget what Greg just told you happened and just concentrate on what we see that little tenting up. Let's say that does release and that tented area atrophies and you have a little bit of break in that outer retinal layer, and you got a person who maybe has a 20/25 acuity, and you're seeing the patient for the first time, and they come in, they have this little disconcerting area, missing area, and they have a little bit of vision reduction. Well, that's probably what happened. What you're looking at, that's what came first.
And we see those from time to time. People will say, "How did that happen?" They blame it on lasers and certain things.
Mhm.
But if they have that
Or
full thickness
solar.
PVD, Yeah, or solar. Yep.
Solar retinopathy.
Yep. Solar lasers. Yep.
Mhm.
But sometimes if they have a full PVD, I bet you that's what happened right there. So take a look at this 30-year-old myope that comes in. After seeing this case, right, you're like, oh man, 30-year-old, lots of glue still here. They're not old. This thing's gonna tear, right? This thing's gonna tear and rip. And look how this is influenced. Look at this. Look at this GCC over here. This one's saying normal GCC. This is saying abnormal. This is the normal GCC over here. But this is being pulled up. But anyway, this is what she looks like close. This is the right eye. This is the left eye. I measured it here just to kind of show you. So this would be a focal. She's young. She's at high risk. Explain it to her. She needs to come back. She comes back. And whew, she was lucky. Look what happened right here. I got them both right here. I'm just going to blow it up for you right here. This is where she was on 317 with that focal vitreomacular traction. Here it is released, let go. Pretty young, 30 years old. So it's not always happening to older people. Happened to this younger person, a little bit higher of a myope, but a little bit higher risk, I'm sure, of that vitreous pulling away at a younger age.
And I think this is probably a good representation of that patient I described to you earlier, where she thought she was developing another macular hole in her other eye, and she had a pristine OCT. Every cut was fantastic, but I had a description of what probably was on the left, and it released. She thought she was getting worse. I couldn't convince her she was probably getting better. And as I said, she probably thinks I'm FOS and went to another retinal specialist.
There you go. All right, let's see. What's this one here? All right, we got some vitreomacular traction here. This eye looks pretty good. This is what they look like on wide field imaging. There's probably a BVD in here somewhere. And it released. So no PVD comes. It's just a vitreomacular traction, not an epiretinal membrane. So vitreomacular traction, nothing really showing up here, and then it released. So, all right, let's see.
I think
Where
we
are
might
we?
want to start
Oh,
landing.
yeah. Well, we didn't get to any of the angiography. It looks like I have to come back and do angiography, Joe. So we'll start landing it right here.
Hey, the Rolling Stones don't play every song they know every show.
That's right. That's exactly it. So here you can see the PVDs. Here is the lamellar hole. All right. We'll just skip this here. Do you need a dye? You do not need a dye. And you basically it's non-invasive. I'll show you in 2 minutes here a real quick case of what I want to show you how this can really work in macular degeneration. Remember, we're showing diabetes here. Here is the outer retina. Here's the choriocapillaris. This is the way it's supposed to look. I'm not going to do the polling question to save time. Is there a choroidal neovascular membrane here? Yes, no. There must be since you're asking. And then would a fluorescein angiography, would it find it? True or false? So right here, there's the arrow. Would you think that there's a choroidal neovascular membrane here? And the answer is, since I'm asking it, the answer is yes. I'm going to take this away right here. You can see the choroidal neovascular membrane. Would the sodium fluorescein find it? The answer is no, for 2 reasons. It's under the RPE, and sodium fluorescein cannot see under the RPE, and it's not leaking. Remember, fluorescein works on things that leak. And so I'm going to end you with this, is that we are calling these occult non-exudative choroidal neovascular membranes. And we're really not sure what to do with them. If I follow these and I find them, I will send them to my retinologist if they're progressing rapidly and they're getting bigger. They will do an anti-VEGF or Vabysmo on them. But I mean, I really have to document and print and send over the different files because this is where technology is a little bit ahead on what to do. I can tell you I've done some heavy antioxidant lifestyle changes and seen these reverse in people. So there's a couple ways to attack those that are out there. So I'll pause there. Sorry, someone asked about getting the diabetes. I did not get to the diabetes part. Just barely touched on some of the angiography, but Joe, looks like I'll have to come back and finish up this talk.
In show business, it's always better to leave them wanting more than overstay your welcome. Now, one thing came through, and I'm going to share with you. I don't think so, but have you noticed more ERMs in patients with high cholesterol? I have not.
I have not. I'm going to beg for a little bit of, because I know what's happening with the with the questions, Joe, with the survey questions. I just want to touch on, remember I talked about diabetes. I'm just going to hit this real quick. This is what it looks like normal on a foveal avascular zone. What happens, what I want to point out is you can see that this looks like normal diabetes, but look how the foveal avascular zone, they're supposed to be round. Look at the dropout that's here and look at the asymmetry. This one's 0.35, this one's 0.2, this one's smaller, this one's larger. When it starts to atrophy, starts to open up, that's whenever you can start seeing the capillary dropout. And again, I'm just going to go through this because I know there's some survey questions. I apologize for going through it quickly, but you can pick up diabetic retinopathy by looking at the foveal avascular zone and measuring it. It's usually the one that's becoming larger is the one that's starting to expand on the patient. And this would be classified as diabetic retinopathy. Now, you can't always say always and never. Notice how here the foveal avascular zone is symmetric. But if you come up here and you look, you can see that there's some macular edema from the leaking. So you can't always rely on the technologies, but I can tell you that I find more diabetic retinopathy early stages, and you can call it diabetic retinopathy because it is diabetic retinopathy. You can code it diabetic retinopathy by looking at these angiographies. And that will just be a little bit of a teaser whenever I come back and finish this one up, Joe.
Sounds good.
All right, so let's go here to this slide, and then I'll share this so that I can tell everyone that right now you'll see that little red dot where it says survey, and you can start that survey right there. And I apologize, I didn't get through all the angiography stuff, but I can come back for that. And with that, Joe, are there any other questions?
Now, the question is, can ERMs disappear by themselves? And the answer is generally no.
Yeah, that'd be kind of hard for something that's additive to disappear. If it disappears, I would say it was probably something else. Anything else?
Nope, we're good.
All right. Well, I want to thank everyone for attending. And this was OCT and OCT angiography. We didn't get a deep dive into the macular degeneration and diabetes. However, we did cover OCT angiography and what the normal and abnormal would look like in some of the cases. So real world cases for enhanced interpretation. I want to thank everyone for attending. Joe, any final comments?
No, I think the title was exact. Real world cases. They really helped enhancing interpretation. I'm going to probably say most everybody who attended probably at one point thought to themselves, "Oh, I didn't know that."
Perfect. So with that, we're going to end the education.